just want to make sure we're working here. Okay, so thank you so much for joining me for the next presentation on head injury. Although I do perfectly understand, being the Friday of Christmas, that if you need to go, you need to go. Don't hesitate to contact me if you have any questions about any of this content. I'm more than pleased to help you. And I've given you some guidelines as to how to make your studying more succinct and to make it more concise and easier for you. So we're going to be talking about clinical manifestations and nursing management of someone experiencing increasing intracranial pressure. We're going to be talking about mechanisms of head injury. We're going to be talking about some of the tests that you will do with someone experiencing head injury. We're going to be talking about different health conditions such as tumor, head injury, seizure, and MS. That doesn't cover everything that there is to know. And what I do is what is going to be most common for you to experience in the clinical or the practicum setting is how I sort of set it up. But also you can extrapolate. So if you talk about head injury, the same principles of appeal are applied to patients experiencing a stroke. You'll need to decrease that intracranial pressure. So you'll be able to take this information that you learn and apply it to other disease entities. So what is a head injury? And so that's a trauma to any area on the skull, the scalp, or the brain. It's a head trauma that includes an alteration in consciousness. And so a very serious form of head injury is referred to as TBI, or traumatic brain injury. And this is quite traumatizing, and it really is a huge burden of disease in our country. I know when I worked at Sunnybrook, we used to have a lot of young, especially men, in the unit because of that what do they refer to it as, thrill-seeking behavior. And so that ended up with a head injury. Causes of a head injury can be from anything. Motor vehicle collisions and falls are the most common, and as I just mentioned, men are more likely to end up with that kind of a head injury. And the head injury has a high potential for poor outcome. These head injuries are not even, sometimes they happen just sort of one of those things, like they're totally, it's not like something dropping from the ceiling hitting them on the head. It's one of those random acts. And so death can occur with this head injury immediately after the injury, within 2 hours of the injury, and that's why we always are talking about the golden hour, and then up to 3 weeks after. So factors that really predict a poor outcome includes the presence of an intracranial hematoma. So people who have banged their head, and on CT scan they actually it's bruised and they have bleeding into their brain. It's now starting to coagulate, and they have a hematoma formation. An older adult, they do very poorly. Patients that are prolonged with their increased intracranial pressure is very pronounced very quickly, because you remember that this is the brainy vault. This is a bony box. There's no room for anything else in there. And so if the patient has bleeding or tissue, that a big huge hematoma, it can compress brain tissue and cause the patient to herniate or cone. They also look at the Glasgow Coma Scale as a good predictor of outcomes, and so that's why in the Emerge and all the shows you'll see Glasgow Coma Scale, GSF of 8. And just remember that Glasgow Coma Scale, the little limerick is anything GSS of 8, under 8, intubate. So if a patient has a Glasgow Coma Scale of 8 or 9, I'm worried about that airway. They're not able to manage it. They're not rousable. They're not alert enough to manage that airway. So I'm either going to manage it for them by inserting an oral airway, or perhaps an endotracheal tube, but at least an oral pharyngeal airway, and you know how to insert those to maintain that airway. So it's really important that we get these patients, that we get them triaged to the correct center, and that we're able to manage them very quickly. Scalp lacerations, I'm sure this is no surprise to you, but they're, as I said, it's a very vascular area, and they bleed like crazy. oh my gosh, there's blood everywhere because they are, there is so vascular. The major complication of scalp lacerations is infection. And of course, you've got hair, you've got gravel or asphalt or some other stuff, and they end up with an encephalitis as a result of that. There could be a skull fracture. And so I just want to remind everyone that a basal skull fracture is at the base of the skull. This is not the base of the skull. The base of the skull is anywhere that the cranium touches bone. So it could be anywhere from the frontal over the round behind the ear and down to the occipital region. So it could be a small fracture, a linear fracture. It could be opened or closed. Open is, of course, always a big concern for meningeal irritation. Types of skull fractures, the location alters the presentation of the manifestation. They might have, in fact, a facial paralysis. They might have battle sign, and battle sign is that bruise around the eyes. Yeah, that is battle sign. And then they have, what is the sign when they have bruising around behind the ears? It's just escaped me. And so they might have these raccoon. Oh no, battle sign is bruising around the ears, and raccoon eyes is they have these big round rings of bruising around the eyes. And it's very upsetting to see some family members, older adults, that have gone down and have they've fallen, they have a skull fracture, and they have these big bruised eyes, and it's very upsetting to the family. This is a good example of battle sign, and when I see that, as you can see, this is healing. The patient has bruising behind the ear, and you can see that linear fashion. Patient perhaps lying down, but I look to see, is there any oozing coming from the ear? Looking for autorrhea or rhinorrhea. So that CSF leak that comes out the ear or comes out the nose. Oh, here's a really good picture of raccoon's eyes or battle sign. And so you can see the raccoon eyes here, which is preorbital edema, but also that bruising and then bruising behind the ear. If I saw clear fluid oozing out of somebody's nose or their ear, sometimes you don't know, is it really, especially the nose, is it mucus? What exactly is it? And so you might need to test it for a halo sign. If there was enough, you could send it off for and dipstick it for glucose, because there shouldn't be glucose. But you could dip, and as you can see on this, I would use a 2x2 gauze. So I would have a drop or two onto the 2x2 gauze, and if it is blood, it's going to separate out and have this halo sign. So you're going to have blood sort of in the center where it's deposited, and then that CSF will leak out around that, and that's referred to as halo sign. And I think we've just talked about that rhinorrhea or autorrhea indicate that there is a fracture. Types of head injuries, concussions, and I just want to remind everyone that concussions are now such a huge thing. You know, it's not as just a minor little bump on the head that they once thought they were. There's a lot of resources being spent on dealing with concussions and long-term effect. The long-term effect is quite astounding. I don't know if anybody's had a sports injury where they got a concussion, but they're now saying that people that have a mild concussion, and that might have been a brief loss of consciousness, you may not even know how long, there's a brief loss of consciousness, but still considered a concussion or a mild concussion, and it has disruption of this axon, or this neural activity. There's some stretching of some of the brain cells, and it takes a long time for that to heal. So patients are they're finding that they have that amnesia, headache, that they have short attention span, that they're very listless. And so a situation that came to my attention not long ago is that there was a patient working in a factory, quite a well-known factory, and they have these security doors, and the security door came down off its hinge and knocked him in the head. And he was concussed, and so they didn't want to let him stay at home and just become debilitated. So she had somebody pick this worker up at home for about 3 months and drive him to work, because he couldn't concentrate enough to work. to drive, and the work was really menial, so it was okay. He didn't really require it, but the concentration was so intense he could not. The thinking was too hard for him. So there's a lot more around concussions. Dr. Tater, Charles Tater at Sunnybrook has done a lot of work with sports injuries, and they're actually seeing people that play sports such as football, even some hockey players, that they have permanent brain damage. And they're looking at their brains and examining them at death. They're having permanent brain damage because of concussion. So just really wanted to highlight that that's really quite major. Post-concussion syndrome can last 2 weeks to 2 months. It can last longer. So I've seen post-concussion syndrome last for a lot longer than that. So typically somebody's had an injury, they take them out and just no activity, nothing that's going to cause increased flow to the brain. They end up with being basically just a limited activity for about 2 to 3 months, then gradually increasing as they can tolerate. The sad part is that they do experience personality and behavior changes. They have no short-term memory. They're very frustrated because they can't remember anything, and they actually have alterations in their cognitive ability. This is the technical term, as I was mentioning, for the axonal injury. So those, to me, it just they stretch the brain cells, and so then you get this because of the irritation of that brain cell. There's swelling at the site, and it actually becomes disconnected or rips in half, and so it's really quite concerning. And some people actually really stay in a comatose state. So just to remember that with traumatic brain injury, it's not always evident initially how much damage there's going to be. That's considered the primary injury. There can be secondary injury as a result of the swelling. And so always looking for alterations in the level of consciousness and signs of increasing ICP. I just wanted to highlight the terms decorticate or decerebrate. And you might remember that from health assessment. I'm hoping those terms aren't new to you. But when you're assessing your Glasgow Coma Scale, and we talk about, you're just going to arouse the patient, Leslie, are you okay? And there's no response. And so I'm going to step it up. I'm going to get right to her ear, get right to the patient's ear. Leslie, are you okay? Can you hear me? And if there's still no response, I'm going to get them to respond to painful stimuli. And remember that we don't do that grinding your fist into their sternum, the sternal rub, for a variety of reasons. One reason is that it can cause damage to the sternum, especially for our osteoporotic little old, 88-year-old ladies, that you can damage their sternum as you crush their sternum. So we do a trapezius squeeze. So we squeeze out the trap, and you'll get a good response if you do a nice trapezius, and there's no damage to anything. They also might have bypass surgery, and if you start pressing on that, you could actually cause them to dehiss. So I tend not to do a sternal rub, but more trapezius squeeze. Do remember that if you're looking at, and for when I'm doing the Glasgow Coma Scale, I'm going to do peripheral stimuli because I want to see how each limb responds. And remember that you're going to take a pencil and apply it to the nail bed for 20 seconds. Firm pressure for 20 seconds. If they're awake, they're going to pull their arm back. Sometimes if they're awake but not alert, they might start to have movement in other parts of their body, and indicating that they are responding to it but not appropriately. So they're not pulling their arm away, or they're not grabbing you to try and stop it, but they might be kicking their leg or doing something else. Now, if they're in a really deep coma and they have damage to part of the top of their brain area, they might have decorticate posturing. So I just want to highlight that that's when they bring their arms towards the core. They flex their arms and bring them towards the core. They bring their hands and they clutch their fingers. So that's decorticate, towards the core. They extend their legs, so they stretch out their legs, and they extend their legs at the same time. So that is decorticate, towards the core. Decerebrate is when they actually extend their arms at their sides and pronate their hands. That is decerebrate. Decorticate posturing is a better indicator, a better sign, because that means the pressure is not pushing to the back of the brain. It's still up here, and you can take measures to decrease it. It's in the cortex of the brain, but as you get to the posterior, down to the spinal canal and to the base of the brain, you're getting into the motor, into the cerebellum and all those areas down there, the respiratory center, etc. As you're pushing pressure from the cortex of the brain back, the brain is going into the spinal canal, and it's acting like almost like an ice cream cone. So that's where that expression came from, coning. So the brain tissue is being pressed and squeezed into the spinal canal, and that's referred to as coning. And what's the other term for it? It's just escaped me. And so I just wanted to highlight that there's major brain trauma. It can be contusions or lacerations or both. Bruising could be, you could have focal area. So remember that there's 3 layers to the brain, that the brain. So you have the skull, and then you have the dura mater, which is that tough external protecting the brain, and then you have your arachnoid layer, and then you have that delicate lace that sits right on the surface, which is your pia mater. And those are the meninges, and the meninges can get infected as well. This is a good thing to remember because of the way the injury occurs. This is referred to as counter-coup injury. And so this occurs when the patient has some kind, it hits the wall, hits the car, even gets punched in the head. There's something that actually they strike the frontal portion of the forehead, and that first area of the brain strikes that surface. And so that is where the primary or the first area of injury is. And because the brain is encased in bone and CSF, it's sort of floating in this hard case, the brain is actually, by force, is shoved back into the back of the brain. And so you have the second area of injury. So this is considered 2 areas of injury, one being coup and the other being contra-coup injury. So it's on the opposite end of the impact. Laceration. So the brain can actually, because of fractures in the skull, it could actually come apart. It could actually be lacerated and separate. You can also get penetrating injuries of the brain. So again, high risk of infection with these types of lacerations. Large lacerations, poor prognosis. Epidural hematoma. And so you can have an epidural hematoma or a subdermal hematoma. And so there's bleeding between the dura and the inner surface of the skull. And so you can have an epidural hematoma or you can have a subdermal hematoma. And it's really good to just subdural hematomas and epidural hematomas are medical emergencies. What happens, especially at this time of year, I don't know if you realize it, but there's a lot of people that actually die from putting up their chapter in the book. I'm not sure. I don't think it's 59 though, Brian. I'm not 100% sure. I'll have to defer to 59. Okay, good, 59. And I did post this PowerPoint as well in the file for neuroemergencies. So epidural and so what happens is people are hanging up their Christmas lights and they fall and they end up getting a bit of a hematoma, but they don't really go to the hospital. It's Christmas season, etc. And they'll end up with this slow bleed into the subdural space. And then 2 weeks later, they're unconscious, and they find that they have a subdural hematoma. Patients are at high risk because they're all on anticoagulation right now. Either aspirin, antiplatelet therapy, or other anticoagulants. So they end up with quite pronounced bleed. So it could be an epidural bleed. As you can see, the epidural in the epidural space and the epidural, or it can be below the subdural space and bleed in the subdural space. And again, what you may not realize is how much space that hematoma is taking up and compressing on this brain. And here's another really good picture of what a hematoma would look like on the brain, and how much room that is really taking up. And you can see that there's a main spot, and then here's the other areas that are bleeding as well. You might see a bit of bleeding there. So, classic signs of hematomas would be an initial period of unconsciousness, then they become lucid, but it's this alternating level of consciousness, headache, and nausea and vomiting. And so this vomiting is actually considered projectile because it's pressure on the vomit center. They just vomit with such great force. So they require rapid surgical interventions and to manage the ICP. What happens often is that I told you they go home, they sit on their couch for 2 weeks until it's too late, but also they get to a center that doesn't have a neurosurgical unit. So Lakeridge wouldn't be able to do it. It wouldn't be, so the thing is they need to be triaged quickly so that they can get to these other hospitals in time to have surgery. We've talked about our subdural hematoma. It can be a arterial bleed or a venous bleed as well, usually venous in origin. So, subdural hematoma, as I mentioned, patients hanging up their Christmas lights, they have a bad fall, they're briefly out for it, their wife comes and helps them in, and then they just stay at home and take it easy for a couple days, and it can, as I said, slow bleeds can take up to 2 weeks to really have any signs. Typically, acute subdural will present within 24 to 48 hours after the injury, and remember that you've got this box. The brain sits in this box and there is no room for any kind of movement. And so as the pressure increases, the patient will then become drowsy and confused, and they will have pupil dilation. And this is when you see that pupil that's fixed and dilated. Remember that the early sign of increasing intracranial pressure is a unilaterally dilated pupil that may or may not react to light. So early sign of increasing intracranial pressure is a pupillary change with one pupil being just a tad larger. One's a 3, one's a 4. It's still reacting to light, and then it doesn't react to light. And so looking for those early subtle changes. As the brain tissue is getting more compressed, the pupil dilates and becomes fixed. And we talked about that just a moment ago. And as the tissue becomes compressed, I just want to highlight some of these important pieces around the brain. So if your brain is now increasing because of hematoma, there's no room for that. And so as part of auto-regulation, and I hope this all makes sense to you. If not, fire me off an email. As part of auto-regulation, the brain will, because if there's an injury to the brain will actually decrease the 3 components of the brain tissue of the box. Three components are brain tissue itself, CSF, and blood. And so when you have increase in one of these components, the autoregulation says it will decrease in the other. So as you have increase in brain tissue, you're going to have decrease in CSF production, decrease in blood flow. And how does the brain do that? It's going to cause vasoconstriction. And autoregulation will cause it to vasoconstrict, to decrease the amount of blood flow in our brain. So it's important. And so this is referred to, you may have heard this before, this is referred to as the Monroe-Keeley hypotheses. Not that I'm going to ask you a question about that, but it has stuck with me all these years. So remember that this is a hard core boxed with and it's tight. And so once there is an increase in one of those elements, either brain CSF or blood flow, there's a decrease in the others. So there's a decrease in CSF production. And as there's increase in this pressure, remember that we've got this pressure on the cortex, it then goes down to the back and really puts pressure into the base of the spine or the base of the neck and causes it to herniate or to cone. Diagnostic tests, nothing to surprise here. You're going to do a CT scan. If there's time, or they may do an MRI. We tend not to do a lot of PET scans, although that is on the horizon. Transcranial Doppler, they'll do those sorts of procedures at Sunnybrook. They'll do brain surgery through the nose, and that's where they have that sophistication at Sunnybrook. They might do C-spine x-rays, really important that anybody who has injury from the shoulders up, if they fainted, fallen, been hit on the head by a door coming down, if they've been punched in the head, anything from the shoulders up, they should have their C-spines protected and collared and boarded until that doctor has cleared the spines. So they'll come in from a trauma, they'll be boarded. We don't touch them as nurses. We don't touch them. We don't put the collar on or off. That would be maybe specialty training with special merge nurses, but we don't do that as routine unit nurses. And so the patient will have a collar on, then they're going to go off to x-ray, have C-spines, and then my point to you is that they need to have it written. C-spines are cleared. There's no C-spine fracture. They're worried that if there's a high C-spine fracture that a little bit of movement can cause paralysis. So if it's been deemed no C-spine fracture, then the patient can be taken off that board and the collar removed. But make sure that before you do anything that it's written as an order. I've seen it too many times where in a hurry they'll say, yeah, I looked at the x-ray. Leslie, I've looked at that x-ray on that patient that just came in. Their C-spines are cleared. Take the collar off, get them up to the floor. Well, when the next day the x-ray radiologist looks at it and says, oh yeah, there is a fracture, put the collar back on, then someone will come looking for me saying, well, who cleared them? Well, Dr. Smith did. Yeah, but he was talking about another patient. So it really sets you up. So really, it's very important in eMERGE when you do your placement that if someone has cleared the C-spines, it's written as an order. C-spines cleared. I want to know who looked at that x-ray and who cleared them. Treatment principles they're really around preventing any kind of secondary injury. It's really to get timely diagnosis and get them into the OR if necessary. They may need, because of increasing intracranial pressure, they may need to have a burr hole. So a burr hole is done in eMERGE where they just put a little circle out of their brain, and so they take away the skulls to allow for expansion. Otherwise, that brain would be compressed. So important to do the Glasgow Coma Scale and to do it as baseline for all of your patients, and then looking for those looking for those subtle changes in their neurological status. And so really looking for any change in their vital signs. And I want to highlight, and that might be a question that you're asked at some point, are vital signs an early indicator of changes in neurological status? So are vital signs a good indicator for increasing intracranial pressure? No. Change in vital signs is a very later finding. And so as you know, we have Cushing's triad, where you get that systolic hypertension and you lose, so that sort of widened pulse pressure. You have the heart rate dropping because of pressure on the base of the spine as the brain tissue is being pushed down. You get increasing, you get bradycardic, and then you get an irregular respiratory pattern, and that's referred to as Cushing's triad as a result of increasing ICP. So the goals of nursing for this patient are really to maintain adequate cerebral perfusion and to decrease ICP and prevent complications. So a couple things I do for maintaining ICP. So first of all, I keep a very quiet environment. I'm not going to be yelling to my patient from the patient's bed. I'll call the nurse for you. You keep it very quiet. There's no discussion with the team over the patient. In fact, I'll lower the lights just because that tends to keep the voices down. So I'll lower my lights. I don't want the heat from the lamps either. I don't want the ambient room temperature. I don't want it to be too hot, the lights to warm the patient too much. So I want to make sure that I keep the room quiet. I control the flow of traffic. The family want to be there, and I encourage family presence, of course, although they want to touch them all the time. I don't want that. So I'll bring the chair and I'll put it into the corner so they can watch everything. They can watch me, but I don't want them to be disturbing the patient. I'm also going to make sure that the patient's head, shoulders, and hips are all in proper alignment. I don't want flexion at the hip, because I want CSF to drain by gravity. So you make sure everything is in perfect alignment so that you have good CSF flow. I'm going to make sure that my bed is in, we typically put them in reverse Trendelenburg to prevent that flexion. So if you go to the bottom of your bed, you know how to put them in Trendelenburg is head down. And we don't do that anymore, but that is referred to as Trendelenburg. So what we do is we keep the bed flat and we elevate the head of the bed 30 degrees. And you're going to spend the entire shift pulling them up the bed as they slowly get, but that prevents that flexion in their hips. So you're keeping their head, shoulders, hips in alignment. CSF can flow freely. You're going to maintain adequate cerebral perfusion. So remember that if you could measure the, and we can actually put measurement monitors on our brain. If you could measure your ICP, it would be between 5 and 15. And so as patients become more agitated or something, then their pressure can drop or it can increase quite dramatically as well. So if their fluids are low, or they're bleeding out, or they haven't got enough fluid, their pressure can drop, or it can increase with agitation. This cerebral perfusion pressure is dependent on the mean arterial pressure. Remember that the mean arterial pressure is the average of systole and diastole. And so the mean arterial pressure, and often we'll follow a mean arterial pressure more often than we will, especially for sicker patients, because I want to know what the overall, I don't want to know their systolic is 140 and then find out that their diastolic is only 40. So I follow their mean arterial pressure. And because we know that the mean arterial pressure is 2/3 systole, the calculation, there's a math equation that you could calculate. And so the cerebral perfusion pressure, which is a number, is dependent on the mean arterial pressure. And that, again, that's another equation. I don't want to bog you down, but I want you to know there's a relationship between your blood pressure and the perfusion of the brain. And so that mean arterial pressure, as it climbs too high, puts too much blood into the brain. It compresses the brain tissue. That little tiny vault is now stuffed, and so that's too much. So now bleed, they'll do something to bring down the pressure. So the mean arterial pressure is too high, it compresses brain tissue, and if it's too low, there's not enough blood flow to maintain the metabolic needs of the brain. So it's so crucial that the blood pressure is just kept right to maintain cerebral perfusion pressure. The patient needs to have an adequate, maintain a normal temperature, a normal body temperature. What sometimes can happen is they lose the ability to auto-regulate, and they can become very hyperthermic, and quite often these patients do become, and you'll find that with your stroke patients, that as the pressure in their brain gets increased, you give them a Tylenol for that high temperature and it doesn't touch it, because it's not an inflammatory process. It is now a structural process. And so that patient who's normally at that temperature, now the temperature center is now all askew, and so they have these really, really high temperatures, 42. And so I'm going to then need to bring that temperature down. However, I want to caution you, the patient can't shiver. Remember that shivering increases the metabolic demands. I can't have that patient shivering. And if you find the patient shivering, you need to report that. There's methods for us to stop that shivering that they do in the ICU. I won't get you to that point today. But the patient cannot shiver, so we need to bring down the temperature slowly, but make sure that it's not too high, because if the temperature is really high, then what happens? Increased heart rate, increased blood pressure, increased blood flow to the brain. So we keep the temperature down. We keep the lights down to keep the ambience room temperature down. We used to use a fan, but fans are now becoming out of fashion because the spread of bacteria, so we don't use the fan anymore. But you might just be able to put on some good circulating room flow. Just turn off any temperature thermometers that you can, and temperature gauges, so you can bring down the room temperature. Keep the patient just lightly covered. I don't want them to shiver, so I'm going to take off everything on and just lightly drape a cotton sheet over them. I'm going to make sure that as I said, the blood pressure is maintained at an adequate level. So I'm going to maintain my mean arterial pressure between 60 and 100, because if it drops below 60, I'm going to lose pressure, blood flow to the brain. I'm not going to nourish the brain. I'm not going to have any kind of nutrients flowing to the brain or oxygen. If it's higher than 100, there's going to be way too much compressing brain tissue. I want to make sure that they're oxygenated, because the brain requires so much oxygen. I want to make sure they're well oxygenated. And so I'm going to make sure that they have maybe some nasal prongs on. I want to make sure that their glucose is at a normal level, because the brain uses a lot of glucose. Making sure that they're pain-free. And so when I was entering practice, they said, oh, don't give them anything for pain, because how can we monitor them? That's no longer the way we practice. We want to make sure the patients are comfortable, because we know that if they're uncomfortable, we may not see them they can't tell us, but underneath they still have that brain activity from the discomfort. So making sure that the patient has adequate pain coverage, that we're monitoring for any kind of temperature, monitoring any kind of infection anywhere. So we're looking at the temperature, we're looking at the white count. Getting back to the temperature, I just want to highlight, you can give Tylenol to these patients, they don't respond, because it's not an infective process, it's a structural process. And as the patient is increasing ICP, if I'm going to do any care, this is the patient you're going to do basic care. I'm not going to ignore the wrinkle under his back, because that can cause another problem. But I'm going to give him the basic care and then leave him alone to rest. Long periods of rest. This is the fellow I'm not going to wash his hair. I would wash all my patients' hair in the ICU in that bed trough. I'm sure that maybe you didn't have Professor Cummings in year one, but she used to teach everybody how to use the bed trough, and that is a dying art, because now we have all those Sage products where you just put it on their head like a shower cap and massage it in. I used to get out all the bed trough and wash the hair and rinse it out till all the blood was out and all the glass was out. Anyways, this is not the patient you're going to do that to, because you don't want to increase the pressure in the brain that's going to cause the patient to cone, or the brain tissue to be forced down the spinal canal. You want to make sure that as the patient is becoming more responsive, that you're orientating them to all the time, that you are orientating them to reality. Do remember, anybody with a frontal injury, because that's responsible for judgment, it's responsible for behavior, personality, they can experience severe personality changes, but more importantly, they can experience profound lapses in judgment. We had a man here in town that had a brain injury. Young man fell in his bathroom and laid there for 3 days because nobody was home, and it wasn't until somebody came looking for him, and he ended up experiencing this frontal lobe injury, traumatic brain injury. And he had one of those motorized scooters, and during that ice storm we had a couple of years ago in December, he was out riding because he wanted to know what it's like to ride it on ice. So totally lack of judgment. And their behavior, they're going to ask you the same questions over and over because they've forgotten the answer. We just have to just tell them the answer, because that's just the condition that they have to live with. Again, always watching for health promotion opportunities. So always wearing car seats. Motorcycle accidents are always a hazard, so really watching those. Wearing helmets and seatbelts, really important for health promotion. I think we've talked about maintaining cerebral perfusion, looking for those changes, subtle changes in cerebral ischemia, looking for that widening pulse pressure, that drop in the heart rate, and that irregular respiratory rate as indicative of cerebral ischemia. I also want to highlight that you remember the coup counter coup injury. So you may find that the patient has personality changes and patient has lack of judgment, but also you may find if they've hit the back of their skull, that's responsible for vision and sight. That's the occipital region. They may have changes in their vision as well. And then you may need to prepare the family for long-term care of this patient. And where does this patient go after the hospital? So I think we've talked about this. Yeah, eye problems, and I just wanted to quickly talk about, and I think I talked about this before. So when I'm checking a patient that's really deep in a coma, I've checked and they're not responding. I've checked with the pen for pain. I put the pen on my, and don't forget, doing a pinch is not doing anything. If you see someone pinching, I would stop them, because that could even be construed as being harmful to the patient, because that's not evidence-based. You need to take the pen and apply it to the nail bed, for 20 seconds, and I should pull away. So if my patient really is not awake or alert, I also check my gag and my cough reflex. So I'm just going to put a suction catheter to see if they gag. Don't do it so that they're going to vomit and aspirate, but just tickle it to see if they have a strong gag, because if they don't have a strong gag, I'm worried. I want to make sure that they can cough up their secretion, so I may suction them or see if they have a cough. I also test their corneal reflex. So I take a 2x2 cotton sterile square, and I just touch the outer canthus of each of their eye with a different corner. So I touch the left, and then I'm going to touch the right with the outer canthus to see if they blink. I want to see if they have a corneal reflex. I'm worried about the cornea drying and becoming ulcerated. So anyone that's unconscious, you should have Lacrolube or some kind of eye protection. So I would put in definitely eye drops, isopropyl tears, or Lacrolube, and I may even have to put a gauze square and tape that down. I also would check my Babinskis. And so remember, for a Babinski's, you're going to take a tongue depressor and you break it in half, and you take the one tip. Where's my tongue depressor here? You take the one tip, take the one corner of the tongue depressor, and you go up along the back of do a backwards J over the foot. To do it correctly, it's not just taking the narcotics keys and going it up the center of the foot. And you'll see that. Please do not do that. Or the family minivan. Take the tongue depressor, and with the broken tip, you're going to do it around. And so you're looking at the great toes fan and the great toe extends. If they open up and fan, you've got a neurological finding. That is a negative. That is a negative finding in the adult. In a child, that's normal, but positive Babinski's is not normal in the adult. Normally, you should curl your toes if somebody was touching the bottom of your feet. Again, always being observant for any kind of CSF leak through the nares or through the ears. Patients that are experiencing head injuries have high metabolic demand, so you're going to have to get this patient onto some supplements, whether it's an NG tube and supplementing them that way with some kind of high volume or high calorie, low volume trauma nutrients. There's cans of Ensure that are especially made for trauma patients. This patient may need to have a catheter. They're going to perhaps need some stool softeners put in their NG tube, or maybe some enemas. Spasticity. Oftentimes with these, depending on the injury, but neurological injuries, they'll end up with spasticity of their limbs. Very painful. So it's just a spasm. It's just like you had a Charlie horse in your foot. If you've ever experienced those, oh my gosh, this is what these patients experience all the time. seizure disorders. And so I really want to just talk to you for a moment about a seizure. And so when seizures, of course, to me, seizures are like angina of the heart, seizures are to the brain. It's when there's this misfiring all of the stimuli, and the patients will have this general variation of, but they'll have this general clonic tensing relaxation of the muscle. And it's hundreds of times over 30 to 50 seconds or longer. So they refer to it as a clonic tonic type movement. So it's this alternating relaxation, tensing up, relaxation, and it's all over the body. It's involuntary. The patient's unconscious. And so they call that a generalized seizure now. They had all kinds of fancy names. It's a generalized seizure. And so when somebody, first of all, I'm going to note whether my patient's at high risk of a seizure, and anybody with a brain injury is at high risk of a seizure, as is someone with electrolyte disorder or certain endocrine disorders. They're at higher risk for seizures. If someone's going to have a seizure at high risk, I'm going to make sure that there's the bed rails are padded, so that if I'm not present and they have a seizure, they're not going to bang themselves into those bed rails. I just take a flannel sheet and tape it over the bed rails. Some of the new hospitals will have special cushions that go over that will protect them. I want to make sure that the bed is free of anything that's going to be harmful to the patient should they have a seizure. If the patient has a seizure, if it's witnessed, I'm going to actually time it, because I want to know. Seizures generally last about 30 to 60 seconds. I'm getting nervous because after 60 seconds, these patients are really not breathing. During a seizure, you may or may not, and typically you don't breathe. So this patient's not getting oxygen, and I need to get some oxygen. And so if this seizure was going on longer, I would certainly call the rapid response team or call a code. And they call this status epilepticus. And so what I'm going to do is just protect the patient, protect the head, just want to make sure they're not going to aspirate. Don't ever put anything into anyone's mouth. At one time, we were taught to put a suction catheter in or to put something in to prevent them. Don't do that, because you can harm their they can bite their tongues, or you can damage their teeth. Hopefully the seizure, just protect their head. That's all. So I would just put their head on a pillow and just guide them to make sure that they're not going to bang their head and have a skull fracture. I'm going to watch them. They may become quite dusky and blue. I'm going to time them, and I'm going to call for help. I'm going to ask, because I'm worried about that airway. I don't think they can maintain their airway, so I'm going to ask for someone to call a code, call the team. I'm going to have a bag valve mask so I can bag the patient should I need to. If they don't stop seizuring, I'm going to have somebody do an emergency airway for me of some description, whether that's an endotracheal tube, but they won't be able to get it in because they're clenched. They might have to do an emergency tracheostomy. So I'm going to have somebody come and assist. So call for help. Have your bag valve mask available, because you're going to perhaps need to bag this patient, and your oral airway. Should they stop seizing, you may need to put an oral airway in, an oral pharyngeal airway. And you're going to get an order for an anti-seizure medication. So typically they give some kind of a benzodiazepine, such as Ativan, to prevent the seizure and to stop the seizure. So you could give the Ativan, and then whatever. They may need some long-term phenytoin or Dilantin that prevents long-term seizures. What else I want to mention about seizures? I'm going to protect them. Oh, after the seizure, they end up with this condition that is referred to as being, they're a little bit stunned. Because their brain has been firing all, and they weren't aware. It's sort of it's all stunned right now, and they call this phase post-ictal. ICTAL, post-ictal. And when in this stun phase, the patient will need a lot of supervision. So you may put them into recovery position. They're breathing now, they're responding, but they're certainly not orientated. So you're going to be following them quite closely and they may be post-ictal for 5-10 minutes, or up to, I've seen it, 6 or 7 hours. I think we've talked about that, and I'm going to skip the case study today. But although it's a very good one, and you can do that at your convenience, I'm going to skip that today. So that is the presentation on increasing intracranial pressure or a head injury. And we've covered the pathophysiology, the mechanism of injury, and some of the ways that the patient experiences increased intracranial pressure. And we've talked about the nursing management. We've also talked about some of the complications of increasing intracranial pressure. I think we've covered all the high points of it. And so I'm going to pull up the other PowerPoint very quickly. Let me just see if I can get, okay, so stop share. And thank you so much, everyone, for staying online. Thank you. I really appreciate this. And certainly, I recognize that it's not necessary, but thank you very, very much. I just wanted to talk about muscular sclerosis here in the last remaining minutes here, because we are seeing a lot of MS in Canada. We have a huge population of MS. We don't see that same sort of around the world. This is very much more than other countries do. So I think it's important that we talk about it. But not only that, it's considered a lower motor neuron disease, and I just wanted to highlight some of the nuances around lower motor neuron diseases. So this is stuff you'll be able to apply to other stuff. Multiple sclerosis is a chronic progressive degenerative disorder of the central nervous system, and it's caused by demyelination of the spinal cord. It typically affects young to middle-aged adults, even very young, and women are affected more than men. And some of them have a very slow progression of the disease. Some have a very fast progression, and they can die within 5 years of diagnosis. And so the cause is really unknown. It's related to thought to relate to infectious or immunological conditions, or some kind of genetic factor. There was thinking that it might even be a virus because it's so prevalent here in Canada and not prevalent in other countries. However, the one thing that they found is that you do have an MS gene. So the susceptibility to developing it is really that you have to have that gene first, and then you would develop MS. So it's thought to be first, second, or third degree relatives. So if you have somebody that direct your parent or an aunt or uncle, those are first, second, and third degree. So, and again, it's still very controversial as to what are precipitating factors, but definitely it's closely linked to genetics. But you could have an infection that causes it. You could be under a lot of emotional stress. So, I don't like to say anything, but sometimes people like going back to school, especially when you're going to graduate school. They develop MS because of the pressure of school, and it could be because of a poor state of health as well. You don't get as much sleep when you're in school. You don't eat as well, and so it's this process that is characterized by this chronic inflammation and demyelination of the spinal canal, of the spinal cord, and it again activated by these T cells that cause this blood-brain disruption, and then it causes this antigen-antibody reaction that leads to the demyelination. But the process is that there is this peeling back of the sheath that covers the spinal canal. That sheath functions to support the spinal column. It also insulates it, and you know that insulation is what really helps the transmission of the nervous stimuli. I'm not going to get into the nodes, the Schwann cells, nodes of Rainier, or anything like that. I'm sure you've talked about that, but just to know that there is a demyelination has occurred and with that demyelination, you're losing that insulation, and so the stimuli don't travel as quickly. It ends up that there's scar tissue, and there is slowdown of the impulses. Vague symptoms can occur in advance of an actual diagnosis. So this might occur for months or years. And so they might just have like a little bit of numbness in the finger, or their leg feels a bit numb, but they thought that's just because they slept on it the wrong way. The disease has a process. The disease process has a spotty distribution in the CNS. So it doesn't go like other disease where it's acented. It can be anywhere in the spinal canal. So these symptoms occur over time. But what it is characterized by is this chronic progressive deterioration. And as the spinal cord demyelinates and lose the support and the ability to transmit, they also they deteriorate in the neurologic function. And I had a colleague that taught me everything. She was a young colleague. She used to work at St. Mike's, went to York Central, and was really helpful in mentoring me in the ICU, because, you know, as I think I told you, there was no courses. And so I hope I am. Just want to make sure I'm recording. And so she ended up about 10 years after being in the ICU. And again, I don't think she, maybe in her early 30s. And after having 3 pregnancies, she ended up with MS. And it was just devastating when I saw her, because she was, you know, an electronic wheelchair. She had a dog, a therapy dog. And the therapy dog ended up jumping out of the ambulance ahead of her and tearing a ligament and had to be put down. So I felt for this girl that was previously a healthy and vibrant ICU nurse, and now she's confined to this wheelchair and really feeling that she wasn't contributing to society. I couldn't believe how quickly her disease had progressed. Clinical manifestations. So you do have, you know, these relapses, and then it progresses a bit more. Signs and symptoms, you have these motor problems. As I mentioned, you just get a little bit weak. My knee's a bit weak. I slept on that knee funny. It's really kind of funny. And then you end up with this like a cerebellar problem. So you have like a real tremor. And then, of course, it impacts your psychological state as well. Average life expectancy after the onset of symptoms is more than 25 years. Although I've seen several cases recently where it was really less than 10 years after diagnosis, because it progressed and demyelinated so quickly, whatever the cause of that quick demyelination. Death for people with MS is typically due to some kind of an infectious process, such as a UTI that causes urosepsis, or because of pneumonia. And so clinical manifestations, again, this is just weakness, this random weakness, or paralysis of limbs, trunks, and head. And it can hit any one of those areas depending on where the spinal cord is demyelinated. You could have blurred vision. Speech has becomes a problem because of all the muscles involved in speech, as well as articulating. So they have a real difficult with speech, and even just talking in general, to get the breath to actually speak, they're very tired. And they get this intense spasticity of the muscles. So the muscles get really stiffened and spastic, and it's very painful. And my colleague, she actually went on to medical marijuana for the spasticity in her limbs, especially her legs. At that time, it wasn't legal to have marijuana. We knew it worked for these sorts of situations, but it wasn't legal. And she was put into a nursing home because her family couldn't manage her anymore, because she had 3 growing boys, and by the time we got the boys off to hockey and took care of mom, so they put her into the nursing home, which was devastating for her. The nursing home actually discharged her because they would not let her smoke marijuana, because they didn't have the oil at that point. Clinical manifestations are that there was, again, numbness and tingling, there's blurred vision, vertigo, and that high-pitched ringing in the ears, it's so annoying. They decrease hearing. Chronic neuropathic pain. And so that is very uncomfortable for them. They also end up with nystagmus, so they have the cerebellar influence. Oh, excuse me, I'm going to sneeze here. Okay, cerebellar manifestations. They have nystagmus, where they have, their eyes are jumping. They have ataxia. They have difficulty with swallowing. Again, it's all muscle coordination. They have difficulty with swallowing and with speaking. They end up with, and again, it's the fatigue that overwhelms the patients with MS. It's really, they become deconditioned because they're too tired. They can't get up in that wheelchair. It's just too tiring for them. They become depressed, and it's a vicious circle. They end up with impaired bowel and bladder function. So they end up, because of the spasticity, they end up with a spastic bladder, which ends up with your urinary urgency. So they have this spastic bowel that tenses up, and then you're going to have incontinence. And so again, ends up with UTIs. They end up, they also, because of urinary retention, they may not be able to actually empty their bladder. They end up with this hugely distended bladder. And we know from last week, we do not let a bladder get distended more than 400, 500 mils, because that can create this lazy bladder or flaccid bladder. And they really don't have any sense that they have to void. Again, experience sexual dysfunction, and they may require a consult to the androgyny clinic again. Because they're going to live with this disorder, and in this particular case of a colleague, it was her brother that he ended up with MS and he had that very quick course, as I mentioned. Let me just see where I was. He ended up with this very quick course, and because he was a young man, it was still very important to him. And his partner actually left him when she found out that he had MS. So again, these are issues that we need to address as nurses, and we need to be comfortable with addressing them. If this is the patient population that we're dealing with, we need to be very comfortable with that. And what are the ways we deal with it? And so a patient that I took care of earlier in my career, she had underwear that they were purchased at a store where I guess they have these sorts of devices or whatever. Anyways, she had those underwear that had like a little slit in them, and she was able to put her Foley catheter through that. If she was going home on a pass with her husband or her family, we would often plug her catheter. So if she wanted to have intercourse, that was available to her. So really ensuring that we provide care in a holistic fashion. They do develop cognitive difficulty, and so we need to really help them with maintaining cognition, but also that we don't want them to become frustrated. If they can't find the word, okay, let's just stop. To me, I always say, is it life-threatening? Can you breathe? Are you having chest pain? And then I'll say, okay, let's just take 5 minutes, and you just wait for that word to come to you, or why don't I give you a paper and a pencil and you can write it? And just sometimes that pause, because there's just so much trying to go through their brain. They do have these outbursts, and I don't know whether it's just because they're angry. Here I am confined to this wheelchair, and you get to go on and walk around, and so your life is not any different. And I again, you sort of feel a little survivor guilt there. I thought, when I saw my colleague, wheelchair bound, difficulty with her speech, and she seemed quite angry at her, especially at her mother. She seemed very angry at her because she was put into the nursing home. Diagnostic tests, predominantly they're looking at their history and the clinical manifestations, and there's certain tests that they will do to sort of paint the overall picture. There's no test to say you have MS. There's no biopsy you could do for MS. Again, you could look at the cerebral spinal fluid, and unless they're doing a spinal tap, I don't see that being done that often, but you could. This is the one thing I want you to remember, is the evoked potentials. And so evoked potentials measure the electrical activity of the brain in response to the stimulation of a specific nerve pathway. evoked potentials are tests that measure electrical activity of the brain in response to stimulation of certain nerve pathways. So when we do evoke potentials, that they put their electrodes on the brain, or they actually will put them on the sensory pathways of the arm, so that they'll put a stimulus there and they'll see, is there some nerve conduction delay between the eye to the ear, or is it in our case, we didn't know whether the patient had a paralysis or they were just had still a lot of sedation on board, so they would do evoke potentials. So evoke potentials are assessing the electrical activity of the brain in response to a stimulation of specific sensory nerve pathways. So the wires are placed on as I said, on the head, and they will apply a little bit of a electrical stimulus, and they'll watch that filter through whatever pathways they're looking at. Collaborative care for the patient experiencing MS. Initially they would use some corticosteroids, but really it doesn't do much because there is no cure. There's a lot of fundraising efforts right now to find the cure for MS, but there is no. It's really symptomatic cure right now. And so corticosteroids do often offer some assistance with the decreasing the inflammation. Yes, what else? Some other medications such as interferon, immunosuppressive drugs will be of benefit to these patients. Although some of them also have very profound cardiac effects. So just really to know that there are some immune drugs that will be effective for MS. The one thing that you will be probably more familiar with is administering other pharmacology agents such as muscle relaxants. So I remember that we gave this lady dantrolene, and we're going to talk a little bit about dantrolene and our final week together. Because it is a profound muscle relaxant, they might need some other medications such as like a Ativan or a benzodiazepine to help relax that. They might have some kind of a CNS stimulant because they're so fatigued. And so these are drugs such as Ritalin. They'll get them Ritalin as a CNS stimulant, or Symmetrol. They might use an anticholinergic agent to treat bladder symptoms. So if they're having bladder spasms, they'll want them to void, they'll give them an anticholinergic agent. There's also been good efficacy, some good evidence to support using medications they use for Alzheimer's. So Araricet, that improves their cognitive ability, and then tricyclic antidepressants and anti-seizure drugs. Tricyclic antidepressants, as you know, their off-label uses for pain management, because tricyclic antidepressant will treat that really deep nerve pain, that low dose, but it is also an antidepressant, and it also helps people sleep as well. So not that they need help sleeping, but it helps if they can't fall to sleep. And then anti-seizure drugs, they're off-use dose of anti-seizure drugs, and I'm going to suggest, can you think of one? And if you say gabapentin, you're correct. People with MS may undergo different types of surgery, and again, I think it's still very niche. There's types of surgery such as dorsal column electrical stimulation, and again, just as an FYI, those will help with tremors and that spasticity of their limbs. Physical therapy, so it really requires the interprofessional team to improve the quality of this patient's life. So physical therapy to relieve the spasticity, to maintain them mobile for as long as possible. So keeping them walking for as long as possible, keep them sitting up for as long as possible, and then as they deteriorate, beds that might be able to change their position. Giving them exercises. They find water therapy is quite effective for these patients, of course, under supervision. Because of the demyelination of the spine, they find that lots of healthy vitamins, so megavitamins with cobalamin and vitamin C, so that's like vitamin B. And they're really just supplement. They're not going to regrow that myelin, but they do make the patient feel better and support some of the other metabolic processes. However, again, evidence is very sparse. High protein diet, high in roughage to combat constipation. Again, want to do a very thorough nursing assessment of the patient, a subjective history, looking to see if you could identify any of those risk factors, identifying if there's any progressive pattern. So my weakness started in the same leg, and I guess it's been going on for the last 2 years, and it's been that numbness. So looking for those patterns. When you're doing your assessment, you're going to be sure to look at all of their entire presentation. Do they have that sense of apathy and that giving up? Do they have pressure ulcers? They are subject to pressure ulcers, so we really need to initiate any of the products to prevent pressure ulcers. Spasticity of their limbs is very prevalent. Do they have nystagmus or any kind of a tremor? This is something you may want to tuck away for later. Nothing, I don't think this is on anything too new, too soon, but it's really important to understand that people that have lower motor neuron disorders become hyperreflexive. So if somebody has there's quadriplegic or with MS, if I take a reflex hammer and I do a patellar reflex, they're going to really shoot up their leg. It's going to be hyper-reflexive, involuntary, because of the influence. They've lost the influence of the upper motor neuron. So hyperreflexia is quite common with lower motor neuron disorders. Upper motor neuron disorders, on the other hand, are hyporeflexive. So if I took that hammer and somebody had a stroke or a head injury, I tap their knee, it's going to barely move because of the damage done to their brain. Nursing, you're going to help the patients to improve their overall health status and prevent any kind of stressors, and so that will be really important to minimize stress, remove themselves from any stressful situations. So I'm thinking, graduate school, working on their PhD can cause MS. Not that it causes it, but it's that stress that can cause that long-term disorder. In the person that already has that genetic predisposition, requires a lot of reassurance, if you can imagine. During acute exacerbation, prevent major complications. So again, pneumonia, we know, is a really big problem. Pressure ulcers, so really focusing on that. Avoid fatigue and extremes of either hot or cold. Prevent exposure to infection. This is the patient that's going to need a flu shot every year, faithfully. Again, teaching the patient a good, healthy lifestyle, rest appropriately, eating well, all the special groups, maybe including that vitamins as well, making sure they're drinking adequately. They can be taught to self-catheterize, and they have no increased incidence of urinary tract infection, but they will be taught to self-catheterize. And I'm sure you've seen those commercials on TV. Order your self-catheterization kit from the States. We don't do it as much here. We just give the patient the catheters. And so I won't go there because I think I'm already over time. And so, again, I think we've talked about MS in general terms of assessment. We always do a subjective assessment for all of our patients, trying to put together risk factors, identifying risk factors. Then we're going to do our objective assessment, knowing that there's certain things that we're looking for: tremor, difficulty with speech, difficulty with articulation, problems with voiding and bowels, and looking to see if there's those types of patterns, and preventing complications. Knowing that this is not curable, but it's really improving the quality of their life. And on that note, I'm going to stop it there, and I just want to thank you all once again for joining me this afternoon for this presentation on MS. It's been my pleasure to join you. I will post this link to YouTube and send you the link later this evening. And if you have any questions whatsoever, please don't hesitate to contact me. And if it's all right with all of you, can we do this for our next class in January? I'm more than pleased to do this, and we'll post the YouTube video at that particular point as well. Anyways, I want to just wish every one of you a very Merry Christmas, Happy Holidays, get some rest, and we'll see you bright and early in the new year. Bye, everyone.